And I would thank at the outset BMS, and I would thank all my colleagues and friends for taking out the time and being over here. So, in the coming 30, 40, 45 minutes, we will discuss about Nivolumab. So, this is no longer a new molecule. We have this for a long time, and now we have the data of the long 5-year follow-up data, and we will see how impressive the results, what are the pros and cons of this molecule, and how this molecule has revolutionized the treatment of non-small cell lung cancer. So, as we know, lung cancer has a huge disease burden, has high morbidity and mortality, and the majority of them present in advanced stage 3 and stage 4, and hence it becomes extremely important to deal with the stage 4 lung cancer. And we have the 5-year outcomes of Checkmate 017 and 057 study, and we have the 5-year outcomes of this molecule. This is the first time we are presenting an immunotherapy with the 5-year data. Quite curious to know how many will survive, how many are progression free, what are the toxicities, are there any alarming signs in these 5-year follow-up. So, so if you look into the burden of disease, so as we know, lung cancer is a leading cause of cancer mortality because it affects vital organs, it affects the respiratory apparatus and mechanism, and it translates to high mortality. And you can see it represents nearly 13% of all cancer diagnosis. It has the highest mortality worldwide. It accounts for 19% of all cancer deaths. Among men, 24% of all cancer deaths are due to lung cancer. And nevertheless, even women also develop lung cancer, and even in women, there's a high morbidity and mortality. If you look into the histology and staging, so we used to have non-small cell and small cell. These were the only two histologies we had. Nearly 85% of them are non-small cell and 15% of them are small cell. And further dissecting the non-small cell, we have the non-squamous, that is the adenocarcinoma, which comprises nearly 50% of all non-small cell. And we have the squamous, that is around up to 20%. So adenocarcinoma happens in people, which is unrelated to smoking, whereas squamous has a good correlation with smoking. And we also have other rare non-squamous varieties like a large cell and not otherwise specified variety. So basically, adenocarcinoma is the most common among all of them, and then followed by squamous. And then we have a very small percentage of large cell carcinoma. So this is how the stage is all about. So we have the T stage, we have the N stage, and then we have the M stage. So the moment it is any node positive, it becomes a stage 3 disease. And then the moment it is ipsilateral, if it's a contralateral metastasis, or if it's pleural effusion or pleural deposits, they qualify to M1A, and from there onwards it becomes a stage 4 disease. So majority of them in practice present to us with stage 3 or stage 4 disease. You can see 57% of patients in stage 4 and 22% in stage 3, and a very small percentage of patients, if we are having screening program in place, will pick them in the earlier stage disease. So we have evidence of immunotherapy in both stage 3 and stage 4. So this is the disease burden. I was speaking about 57% of patients with non-small cell present with metastatic disease, even though they have a local regional disease presentation. Even if you have a stage 3B or a stage which is locally advanced disease, as you follow them up, majority will develop metastatic disease at some point. So a huge burden of a huge bulk of lung cancer patients present to us with a advanced disease, and that's the importance of targeting these population with effective therapies. So this is the TNM I was speaking about. Any node positive, it becomes stage 3 disease, and you can see the N2 and then the N3 and then the M1A and M1B being there. And then if you look into the treatment of lung cancer, you can see the number of new cases in India. It's around 67,000, which is quite significant. And the incidence is 6.45 per 1 lakh population and converts to a high death rate, and 5-year prevalence is nearly 65,000. You can see the prevalence is not that high. That means the number of patients who are surviving long is small. So if you have diseases like diabetes or chronic kidney disease, there the prevalence is high because the patients are going to stay, they're not going to die. Because but in case of lung cancer, the prevalence and incidence are almost equivalent, saying that none of these patients are going to live long. So this is the concept that we had before the advent of immunotherapy. But now, after immunotherapy has been used in large set of population, we can speak of prevalence in lung cancer because we have a significant proportion of patients crossing 5-year landmark, which we never spoke in lung cancer. We used to spoke in rare cancers like a low-grade lymphoma or a follicular lymphoma or a CML or a CLL. But today, we are speaking of 5-year survival in lung cancer, which I don't think any of the oncologists thought that anybody will be presenting on a 5-year data in an advanced lung cancer. Quite a surprising, and we need to be proud of the amount of research and effort that has been put into it. So this is the summary of expected outcomes of therapeutic intervention. Over the last 3 decades, the 1-year survival rates increased from 35% to 45%. And then for patients with advanced non-small cell lung cancer, the current outcomes from systemic therapy are also poor. You can see the overall response rates with the first line treatment, hardly around 30%. And then whatever treatment you give, they're going to progress by 6 months. And the median survival is just around less than a year, 10 months. And 1-year survival was 40% and 2-year survival was 15%. So this was the treatment which we had in the last 3 decades. And this is what we have seen in lung cancer, and this is what we know lung cancer is all about, that hardly anybody crosses the 2-year landmark. And to leave apart the 5-year landmark, 2-year landmark was also quite difficult. And you can see in this chart clearly that just 10 to 15% of patients crossing this 2-year landmark. So if you look into the second line systemic therapy, so we all knew that the systemic therapy of lung cancer in the first line was basically a platinum based doublet chemotherapy in those patients who don't have a driver mutation. There was no standard of care for the second line lung cancer. However, after we got the platinum based chemotherapy in the first line, there were a significant number of patients who used to live for the second line. And in this set of patients, there was a comparison of docetaxel versus best supportive care, and docetaxel did show an improvement in overall survival. So in those patients who do not have a driver mutation who has progressed on platinum-based chemotherapy, docetaxel became the standard of care. So we now have agents that target the PD-1, PD-L1 pathway. So they also, especially Nivolumab, has become standard of care in the second line setting. So when we look into lung cancer as such, we just don't look into the disease biology. What is the stage? What is the histology? What is the mutation? Not only that, even the patient factors like the performance status, what are the comorbidities, what are the symptoms, these also become important. So we have some prognostic factors and we have predictive factors for response to treatment, both in first and second line as well. So if you look into the treatment of a non-small cell lung cancer in the present day, we must do a biopsy to get adequate tissue. After getting it, we need to look into what is there in a driver mutation in it. So nearly in around 40 to 50% patients, we can find some sort of a driver mutation For example, in EGFR, in nearly around 30% patients, 30-35% patients, and then we have the ALK, and then we have the ROS rearrangement, we have the BRAF mutation, and then we also have the rare MET, RET, HER2 being present. So these are the targeted mutations which we have, and in those patients where we don't have a target, we must do a PDL1 expression, and if it is positive in the first line, if the PDL1 expression is more than 50%, we can use single agent immunotherapy, especially pembrolizumab. So this is the treatment landscape we have in a patient who is PCOG, ECOG PS0 to 2, in the systemic therapy of advanced lung cancer. We initially look into target mutations. If there are no driver mutations, then we give systemic therapy with a platinum-based doublet, and then we give maintenance with either pemetrexed or bevacizumab. And at progression, we would prefer an immune checkpoint inhibitor over a chemotherapy. So you can look into the options. We have multiple chemotherapy options being there. We have Nivolumab, we have pembrolizumab, atezolizumab, all being there in the subsequent line setting. We also have chemotherapy like docetaxel, gemcitabine, and we have docetaxel plus ramucirumab, docetaxel plus nintedanib. These are the options we have. And if the performance status is worse than 2, then best supportive care should be an option in these patients. So one more important thing is having the palliative care in place. Early palliative care improves quality of life and also has given a non-statistically significant overall survival benefit. So talking well to the patient, taking care of the symptoms, discussing the problems with the patient improves the quality of life and also survival in advanced lung cancer patients. So we have now we will discuss the 5-year outcomes from the 2 phase 3 checkmate trials 017 and 057. We will also look into the pooled analysis of nivolumab versus docetaxel in those patients who are treated with platinum-based therapy in the first line. So this is the 6-year OS in non-small cell lung cancer as per the checkmate 003. You can see the median OS of nearly 9.9 months. Then you can see at 1 year, 2 year, 3 year, 4 year, and then up to 5 years, it's around 15%, and then going on to 6 years, only 14.1%. So what we can see in all the immunotherapy treatment is the tail of the curve just goes on and doesn't fall down at all. So that simply means that if we had 100 patients in the beginning, and we will have that 30 patients, 25, 30 patients who are going to benefit for long, and these patients will have a long-term survival, and that's the reason why we speak of 5-year and 6-year survival in immunotherapy. So this was the basic design of the checkmate 017 and the 057 study. So all of them were advanced non-small cell lung cancer with an ECOG 0 and 1, and they were all exposed to platinum-based chemotherapy in the first line. 017 is basically a squamous non-small cell lung cancer, and 057 is the non-squamous non-small cell lung cancer, basically adenocarcinoma. And the prior TKI therapy allowed for unknown ALK translocation or EGFR mutation, and prior maintenance therapy with either pemetrexed or bevacizumab was allowed. And there was a 1:1 randomization to nivolumab 3 milligrams per kg 2 weekly. There were 427 patients in the pooled analysis, and we had docetaxel also 427 patients, 75 milligram per meter square every 3 weeks. And the treatment was continued until disease progression or unacceptable toxicity. And the stratification was basically based on the region or prior use of taxane, prior maintenance, and second versus third line of therapy. So this was basically in the 057, the adenocarcinoma subset, and the primary endpoint was overall survival, and additional endpoints were PFS, response rates, the efficacy by PD-L1 expression, safety, and patient-related outcomes. So this is the pooled study of randomizing advanced lung cancer patients to Nivolumab versus docetaxel. In checkmate 017 it was squamous, and 057 it was non-squamous advanced lung cancers. So this was the 5-year pooled OS data of Nivolumab versus docetaxel. You can see that the overall survival difference that becomes better and better as the time goes. The median overall survival was 11.1 months versus 8.1 months in the docetaxel arm, with the hazard ratio of 0.68 and with having a narrow confidence intervals. So this is an excellent curve where you can see that initially you look into the progression-free interval. There is a crisscrossing of all the immunotherapy curves with versus chemotherapy. If you look into the PFS or the OS, there will be a crisscross. Initially, they are equivalent in the initial few months, but later on, as the time goes on, the chemotherapy fails where the cells become resistant, whereas immunotherapy clearly demarcates from chemotherapy as you go over a period of time. So as you follow the curve towards the right at 1 year, 2 year, 3 year, 4 year, and 5 years, you can see the curves continue to separate, and immunotherapy continues to work better than chemotherapy. And these are the curves which we used to see in patients who underwent surgery, in patients who underwent chemoradiotherapy, where we used to have that last chunk of 30%, 20% patients who are going to live long. But you can see in immunotherapy how we have a big chunk of patients living long and the tail doesn't come down to the baseline. Yeah. So at 5 years, if you look into the PD-L1 in those patients who had a PD-L1 of more than or equal to 1%, they have a better hazard ratio of 0.61, and again you can see the difference in the curves, the overall survival statistically significant if there is PD-L1 more than 1%. So here the hazard ratio in the overall population was 0.68, and the moment you have PD-L1 more than 1% in place, the hazard ratio is 0.61. So we anyways use Nivolumab in the second line setting post platinum irrespective of PD-L1. But if you have any expression of PD-L1 in this pooled analysis, you can see the hazard ratio becomes better from 0.68 to 0.61 with a narrow confidence interval. So if you have a PD-L1 status less than 1%, you can see the hazard ratio is 0.76, again statistically significant, again the confidence interval less than unity, but the magnitude of benefit you get in patients who have a PD-L1 more than 1% is quite significant. So the curves are widely separated if the PD-L1 is more than 1% versus those patients with the PD-L1 is less than 1%. So we have approval for using immune checkpoint inhibitor, especially Nivolumab, irrespective of PD-L1, based on the intent to treat data we have. Irrespective of PD-L1, there was a overall survival benefit. But if you really want a huge magnitude of difference, the difference is more in the PD-L1 positive subset than in the negative subset. You see the hazard ratio of 0.68 and 0.61 and 0.76, and hence PD-L1 is predictive of response to immunotherapy. So at 5 years, Nivolumab showed durable long-term overall survival in squamous metastatic non-small cell lung cancer. This was a checkmate 017 study. The hazard ratio is 0.62 in the overall population, and the 9.2 versus 6 months is the median overall survival. And in the adeno, again the hazard ratio is 0.70. So 0.62, the squamous does a little better than the adeno. Again, this is in the ITT population. And this is the subgroup analysis of Nivolumab versus docetaxel. So you can see almost all the subgroups have benefited, whether it is gender, whether it is performance status, and if you look into the age, we had a very small subset of patients, around 72 patients in the age more than or equal to 75, and it is difficult to comment regarding the subgroup analysis in small subset population. So squamous, non-squamous, PDL1, less than 1, more than or equal to 1, non-evaluable. In all these subgroup of patients, nivolumab scored over docetaxel in terms of overall survival. So nivolumab is a clear winner when compared to docetaxel in the second line setting. You take it squamous, non-squamous, whether prior maintenance was given, irrespective of PD-L1 expression, it has shown a statistically significant overall survival benefit. So at 5 years, nivolumab demonstrated a sustained duration of response. You can see the 5-year pooled PFS and the duration of response data, nivolumab versus docetaxel. You can see the progression-free survival. If you look into the progression-free survival, docetaxel is better than nivolumab. Uh, 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 so basically, the progression-free survival is almost always better with chemotherapy arm than the immunotherapy arm usually. So you can see the crisscrossing of the curves that we see with immunotherapy and chemotherapy. The initial rapid response is what we get with chemotherapy like docetaxel, but the responses are not sustained. You can see the crisscrossing of curves again in the initial part, whereas if you follow them up later on, the immunotherapy will be a clear winner. You can look into the PFS of 2.5 versus 3.5 months, and then you have the median duration of response scoring significantly over and above chemotherapy with immunotherapy. So the overall response rate was 19.7% versus 11.2% for docetaxel. So this is the PFS and OS landmark analysis by PFS 2 and 3 and at 4 years. So you can see the 2-year progression free, around 45 patients were there, and then 3-year progression free, 29 patients were there. At 4 years, we had 25 patients. So this is how, if a small subgroup of patients in whom this molecule benefits, the benefit is going to be sustained and durable. So the 2-year progression-free survival is 45%, is nearly 45 patients survived 2 years who were progression-free, and at 4 years, nearly 25 patients were progression-free. And you can see the baseline characteristics of less than 1 year versus more than 5-year survivors. You can see the ECOG performance status, quite big number of nearly 56 patients surviving. So the higher there were the patients who had a better performance status was higher in the more than 5-year survivors, and you can see the PDL1 expression of more than 1%. You can see the 5-year survivors nearly had 75% survivors versus 49%. So the treatment status of survivors at 5 years. So you can see in those patients who had nivolumab, look into the 5-year survivorship. So you had nearly 21 progression, 18 progressed on nivolumab, and then 2 of them did not receive subsequent therapy, 19 received subsequent therapy, and then who did not progress on nivolumab, and you can see 5 patients were off nivolumab and 16 patients were on nivolumab. So what we can understand is there is a select subgroup of patients in whom immunotherapy continues to work even after you stop the drug, whether it was due to treatment-related adverse events or because the patient took a call or there was a maximal clinical benefit. So they took a call of stopping them, and in these 5 patients, the patient did not progress even after stopping the drug. So you can see the safety. So we know that immunotherapy or immune checkpoint inhibitors, the PD-1, PD-L1 blockers are not that toxic. You can see the toxicity being there in nearly 26% patients, but we can see the grade 3. So the grade 3 adverse events are really rare with immunotherapy when compared to chemotherapy. And you can see the patients on treatment with first line treatment, you have skin toxicities. The majority of them are grade 1 and 2, and rarely we have grade 3, 4 toxicities. Endocrine toxicities are the most common which we see, and it can be easily handled by hormonal supplementation. And then we have hepatic toxicities, we have pulmonary toxicities, these also being present. So to conclude for the checkmate 017 for squamous and checkmate 057 for the adenocarcinoma, so there were the phase 3 randomized, this is the pooled analysis of phase 3 randomized trials, and if you look into the 5-year outcomes with this PD-1 inhibitor, you can see the 5-year pooled analysis of overall survival of nearly 13.4% with Nivolumab versus 2.6% with docetaxel. The 5-year pooled PFS was 8% with Nivolumab versus 0% with docetaxel. So patient without disease progression at 2 and 3 years after treatment with Nivolumab had a 60 and 78% chance of remaining progression free at 5 years. There were no baseline clinical or tumor characteristics clearly distinguished long-term survivors receiving Nivolumab. So at 5 years, 10% of Nivolumab survivors were off the study drug, that is, they continued to respond or had not progressed in spite of stopping the drug. So with 5 years maximum, 5 years of minimum follow-up, no new safety signals were identified for Nivolumab, and there was no evidence of late onset grade 3-4 toxicities. So to summarize and conclude the topic, so now that for the first time, we have data on immunotherapy, the 5-year follow-up data. So what we could understand and summarize finally is, yes, in lung cancer, we are speaking of 5-year survival data in advanced lung cancer. And we have the data of both squamous and non-squamous variety. And we have the pooled analysis. And what we can see is nearly 13 to 15% patients surviving up to 5 years. So those patients who survive the initial 2 years are going to live for 3 and even more. So those patients who are going to benefit from this treatment in the initial 2 years are the ones who are going to be long-term survivors. But it is very difficult in the initial part. There are no such biomarkers or there are no such patient characteristics at the outset to say which set of patients are going to benefit long. So as of now, we don't have a specific biomarker to say, yes, this patient benefits and this patient does not benefit. So we have to treat that 100% patients to pick up that small 15-20% patients who are going to have a long-term survival. So Nivolumab, in comparison with docetaxel, has been a clear winner at every time point in terms of duration of response and overall survival, and also in terms of toxicity. So, and there are no new safety signals with these immune checkpoint inhibitors. And handling toxicities with immunotherapy needs a low threshold explanation to the patient, picking up these immune-related side effects quite early and treating them promptly. So with this, I would like to conclude that if we have a non-small cell lung cancer patient without any driver mutation, and if a patient has progressed on platinum-based chemotherapy, and in the second line, we must consider immunotherapy. Especially, we have Nivolumab, 5-year long-term data over docetaxel, irrespective of PDL1, even though the benefit was better when the PDL1 positive population, but the intent to treat population did show the benefit. So irrespective of PDL1, irrespective of histology, irrespective of whether maintenance was given or not, we can offer Nivolumab as a standard of care in all non-small cell lung cancer patients who have progressed on platinum-based chemotherapy. With this, I would conclude and thank the organizers for providing me the opportunity, and thank you all for attending the meet. Thank you.